So the moderator for session 8 is Dr. Shaila Sheikh. She is a consultant endocrinologist at Saifi Hospital, Vokad Hospitals, and Prince Ali Khan Hospital. She is an active member of the Endocrine Society of India. She's one of our faces of Maharashtra endocrinology, and she's always enthusiastic. And she is the one who pushes all to do more for endocrinology. So thank you, ma'am, and welcome here. I hand over to you.
Thanks for those kind words, Varsha. That was really very sweet of you. And as we all know, we have a very, very interesting session ahead of us. We have a pre-recorded session, but it gives me great pleasure and it's an honor to introduce the three panelists for the day. We all know Chitra. We all know Dr. Chitra Selvan, who's an associate professor endocrinology at MS Ramaiah Medical College, Bangalore. Number of awards to her credit, more than 40 publications, a big voice for patient-doctor communication, and has brought a lot of change in the way we communicate with our patients today. Next slide, please. We also have the very, very, how do I'm still trying to find words to describe Indra. She's one of the sweetest persons I know, the most soft-spoken endocrinologist, and really an epitome of what mind-body medicine should be, who is an endocrinologist from the Department of Endocrinology, R.G. Kar Medical College, Kolkata, member of the ACE USA, European Association for the Study of Diabetes, Research Society of Study of Diabetes in India, and a fantastic speaker, colleague, and a great friend with a number of publications to her credit. And last but not the least, don't go by Sambit's demeanor. He can hold himself in any meeting with as many female endos around. And it gives me great pleasure to introduce a very good friend, Dr. Sambit Das, who is, though Sambit has said is a senior consultant endocrinologist, but believe me, Sambit doesn't look at all like a senior consultant endocrinologist. He's, as I said, another very good friend from Apollo Hospitals, Bhubaneswar, member of a number of societies. He does the obesity week on behalf of ESI, a member of the ESI, of the executive committee of the ESI, and a great colleague to work with. So I think we go to our pre-recorded session and then we can possibly take the question and answers from here. The backend team, if you can play that, please. Hi, everybody. It's such a pleasure being with all of you all today in this fantastic mind-body medicine conference organized by Synapse. And before I say anything further, the first thing I want to say is a big thank you to Vaishali for not only organizing this meeting, but actually thinking out of the box. Conventionally, when we talk about any sort of, I wouldn't want to use the word disorder, I wouldn't want to use the word disease, but any medical problem, we always look at it very physically. We look at it with particular physical connotations. I think that's the way you and me are trained, that we only think about the physical manifestations. We would most probably look at the numbers and think about the numbers. And we like well-defined endpoints. I think we are so tuned to talking in terms of a well-defined issue and then having a well-defined output, that we often tend to miss the nuances of diagnosis, the nuances of therapy, the nuances of conversations. And it gives me great pleasure today to introduce three fantastic, not only speakers, not only colleagues, not only friends, but three fantastic human beings who are thinking beyond this realm. They are now more and more, there's more and more conversations around what kind of psychological impact these disorders have on patients, what kind of impact they have on families, how do they affect our social fabric, and there's so much more to it. And believe me, you're going to enjoy the next 40 minutes of conversation, because I know that I'm definitely going to enjoy it. And I'm going to take the first question to Chitra. We all know Chitra, we all know the great gutso which she talks about patient-doctor conversations, patient-doctor communication. And I'm going to take this to you, Chitra, because she has a great interest in PCOS also. Chitra, is there any evidence to really say that mental health concerns are greater in women with PCOS? Tell me honestly, do you think it is a cause or do you think it is the effect? What would your opinion be?
Right. Thank you so much for that question, Dr. Shaila. And I think it's extremely important to acknowledge that we are beginning to speak about this. I think we've all had a suspicion that maybe, yes, women with PCOS might have greater mental health concerns. But now, over the last decade, we've had large studies coming out from various parts of the world, including large meta-analyses. Now, we now have studies running between 100 to 200 studies which have examined this case specifically, to show that yes, there definitely seems to be a greater prevalence of mental health concerns, definitely anxiety and depression in women with PCOS as compared to people without PCOS. We were fortunate enough to be part of a large community-based survey, which happened between endocrinologists here in India with Dr. Tejal and me, along with the endocrinologists at the University of Birmingham, where we interviewed close to 1,000 women and found out that the prevalence of anxiety was close to 60% amongst women with PCOS, and the prevalence of depression was close to 24%. And we were thinking, but maybe community-based surveys aren't very accurate. And then we looked at in-clinic interviews where we interviewed them and screened them for depression and anxiety. And both of the findings corroborated, suggesting that the prevalence of anxiety and depression was high in people. And now we have large meta-analyses suggesting the same. Now, whether it is cause or effect, I think is a question which we can all debate for. But I think it's a little bit of both, right? PCOS is a very poorly understood condition. We don't really know exactly what the pathophysiology is. And it's a very new condition, relatively speaking, in terms that it was first defined maybe a century or a little more over, and we haven't really understood whether it starts with insulin resistance or it starts at the level of the ovary, whether it starts through inflammation which happens in various organs. So there's really maybe a little bit of both, but definitely this is something that we need to speak about, and I think through the conversation the audience will try and gain some insight into why you and I as physicians should start to care about mental health issues of people seeking help with us. Over to you, Dr. Shaila.
Chitra, that's very interesting. That's a huge number of anxiety and depression. And I don't think even when I am sitting in my clinic, I really take such a huge amount of, sometimes I'm not really aware that, my patient could actually be suffering from such a significant extent of depression and anxiety. So thanks for, telling us about that, because I think that would make a difference in clinical practice, and it makes us more aware that we need to actually look at this much more closely than we do. Indira, if I can take the second question to you. I mean, we all know PCOS, one of the, manifestations of PCOS is hyperandrogenism. And we know our society can be, if I am allowed to put it this way, very harsh. If women especially are suffering from hirsutism, there are, can be memes, though we do have a lot of women out there who are now advocating that you should not really be worried about the hirsutism. But we know there are issues around that area. So what is the evidence in literature regarding psychological issues which women with hirsutism face? What would you really advise us as a clinician? How do we tackle these issues women with hirsutism could potentially face?
Thank you. I think that is a very relevant question. Yes, as we know, hirsutism means there is increase in the androgen-dependent terminal hair in females. So there are lots of causes. There are evidences that women with such a problem do suffer from poor health-related quality of life and psychological disturbances. So if we take a few examples, there was one paper in the European Journal of Endocrinology, leaving from where Dr. Chitra left. So yes, women with PCOS have disturbances in mental health. And this particular paper pointed out that it was more to do with the changes in the physical appearance, for example, the obesity and the hirsutism, rather than, let's say, the oligomenorrhea or the biochemical features of hyperandrogenism or insulin resistance. Again, there was another very interesting paper by Ekback et al. It was a Swedish study. They looked at put in a lot of questions about women with hirsutism, and they wanted to know about the social aspects, about how they perceive themselves, and also about the their let's say interaction with the healthcare setup. And some of the findings were quite disturbing in the sense that some women thought themselves to be actually to be trapped in that body, to be imprisoned. And sometimes they think a feeling of sorrow in the sense that they have been given one life and this life has to be like this. Sometimes they even have an identity crisis in the sense that sometimes they feel that when all this is over, when all the hair is gone, I think that I would be absolutely normal. So yes, they suffer from a lot of stressful situations and thoughts, and we need to be very, very empathetic about these conditions.
That's huge, Indira. That's really huge. I mean, ranging from an identity crisis to talking in terms of, actually feeling trapped. I think we really need to create a lot more empathy for our patients. And I think we ourselves need to create a lot of understanding regarding the issues that our patients with hirsutism face. Sambit, if I can take this next to you, we also know that infertility can be a very, very big issue, especially in our society, where infertility sometimes can lead to so many social issues, with family fabric getting affected, society getting affected. And one of the issues which you often have, you may have a patient sitting in front of you and telling you that, okay, this is really, creating a lot of havoc in my life. What do you think is the psychological impact of infertility? Do we really look at it very closely, Sambit?
Yeah, thank you, Dr. Stella, for that important question. And we all know that infertility is a big problem in our society, and it's not only in our society, across all cultures, across all societies, it is very important. And I'll give you some grim figures actually. And the Indian figure, we don't have the exact figure, but some North Indian studies, they have almost done like 10 to 15% of the couples in their reproductive age can suffer from infertility. And the infertility, as you have told, that it leads to various problems like the couple may feel shame, guilt, and low self-esteem. And all these negative feelings may lead to some serious psychological problems like maybe depression, anxiety, distress, or poor quality of life. And in one of the studies, they have shown that almost 40%, we know there are male factor infertility and female factor infertility, and women actually suffer more with this psychological impacts of infertility. And one of the studies have shown almost 40% of women were diagnosed with depression. In another large studies, they have shown that almost 56% of women and almost 32% of men with infertility may suffer from depression. And the anxiety, if we see the people suffering from anxiety with infertility, it's still higher, almost like 70% in women and 60% in male. But what is more striking is one of the studies which I was going through, that almost 9% of people or women have reported having suicidal thoughts also. And that's a very concerning problem. And this infertility not only happens once the people who have not addressed it, but those people who are addressing it, even going to the infertility clinic or going for artificial reproductive technology also, they also suffer from significant infertility. And there are many medications which we use for infertility, like maybe the leprolide, clomipene, or gonadotropins can themselves lead to anxiety, depression, and irritability. And it has also been shown that those people who are depressed, those infertile women, the less likely she is to start an treatment protocol, and there are more dropouts even if they go for an ART or artificial reproductive technology. So there is a huge impact of infertility on psychological issues.
That's such an eye-opener, Sambit, when we are treating our patients with infertility. I mean, we never realize that, we never talk about it also.
Yeah.
We never really ask them also that, are you okay? Are you really feeling very depressed about having to, go through this? we really never ask. And I think even if the question is asked, we often brush it under the carpet saying, oh, it's okay, you're going to be okay. I think that is the maximum response we give. So, I mean, thanks for that, Sambit. Thank you very much. If I can go back to Chitra. Chitra, do you think that we should now, I mean, for example, physicians, gynecologists, who, are trained in, the conventional medical sciences should now screen for mental health concerns in women with PCOS? Do you think that, it's high time we started doing that? Or do you think it would really overburden an already overburdened medical system? So what would you really think is the best way forward?
Right. And I think this is probably the most important question in this conversation, because you and I have been trained in medical schools to identify symptoms, signs, make diagnosis, and provide management as a prescription. And then that our job ends there. But with more and more people living with chronic conditions, we have to understand that we all, when asked what is the treatment of PCOS, very quickly say lifestyle changes, lifestyle changes, lifestyle changes. But what is the point of saying lifestyle changes if we are not providing tools to make those lifestyle changes, number one? And number two, finding the things that get in the way of making those lifestyle changes, right? And I think that's the area why we should pay attention to mental health. So another entity which is spoken in the context of PCOS is what is referred to as body image. Body image is my perception of my body. It can be distorted because it can be distorted by my thoughts or the way I think my body looks. So body dysmorphism disorder is more common in women with PCOS, which means there's a chronic dissatisfaction with the way you look. And you, like Dr. Indra said, you feel like if the hirsutism goes away, I will start feeling better. If I lose weight, I'll start feeling better. So it's a non-stop endeavor to please some standard that you've set for yourself, which could be realistic, unrealistic, but that is the overwhelming thing in the patient's life. And that might be such a high goal that it might be difficult or impossible to reach, but it seems to snatch away their motivation to implement changes which could provide maybe metabolic benefits, which you and I are trying to effect. And that's exactly why when you say go for a walk and people don't go for a walk, while the easy thing to do is for us to presume that the patient is lazy or are not motivated and all of that, maybe we need to find out what is holding them back, right? Do you feel awkward when you're walking on the road? Do you feel people are staring at you when you're exercising in the gym? Do you feel like you've been exercising, but you're seeing no changes, right? Have we taught our patients to look at the parameters which could potentially change within 2 weeks of exercise or 4 weeks of exercise? So those are all the things that we probably need to now think about, because not only are we physicians giving prescriptions for medications, but we are also people trying to get people to make habit changes, right? So there is an entire behavioral aspect of science which focuses only on changing habits, right? So that is very much related to health science, but we doctors seem to think that we probably don't need to reach out to them because we know all the ways to do it. But if you and I have ever tried to change a habit, build a good habit, break a bad habit, you and I know how difficult it is, right? But yet we've not normalized reaching out for those specialists to become our allies in this care of multidisciplinary aspect of PCOS care, where we can bring in meaningful inputs from all of them to effect more change. So I think that's why all of us should screen for it. It's okay for us to not know what to do, whether there is depression or anxiety, but there are experts who could probably help the patient cross over that bridge to do better for themselves, right? And I think that's why we need to have this conversation. Over to you, Dr. Shaila.
I think, Chitra, you brought a very important point to the table, multidisciplinary care. I think we need to evolve as far as multidisciplinary care is concerned. And as you said, I mean, it is okay for you not to know what to do with the mental health concerns, but you can definitely refer the patient to the right person who can then probably tackle the mental health concerns and look after our patients better. Just a little offshoot of that, Chitra, if I'm allowed to. Do you think, I mean, you spoke about body image dysmorphism, which, every person goes through at some point of time when they're suffering from PCOS. I really want to know from you, do you think our social media contributes to it in a very big way at this point of time? And do you think, as clinicians, we should also be sort of using that as one of the ways to reach out to our patients? Just an offshoot of what you just told me.
So I think that's a very valid point, Dr. Shaila. I'm secretly grateful that I passed over adolescence and moved into adulthood without the presence of social media, right? I'm secretly grateful because the peer pressure which the current youth and the current adolescent face is immense, and something that you and I will never be able to understand at all. So only recently I got onto that social media where videos and photos and filters are the theme predominantly. And I was shocked by the amount of pressure a young girl could be under, be it, so you and I could make mistakes and it'll be maybe stored in somebody's brain, but there's no evidence at all. But in today's world, it's all out and the entire world is easy to jump in. So that's exactly what I tell all mothers or parents. Mothers tend to be slightly more critical of girls with PCOS when they come in and say, ye to kuch nahi karti hai. So to say that, we don't know their world, you and I don't understand it at all. And you don't have to understand it completely to be supportive.
Yes.
It's okay to not understand, but just know that she's facing her own battles. Like I will never understand your battles, right? So I think it's very, very important for us as doctors to be the bridge between, let's say, the hypercritical parents and also the struggling adolescent and adult, because they've truly not found their voice. They've truly not found all their resources and tools. And thanks for bringing this point up, Dr. Shaila.
Thanks, Chitra. That was fantastic. Indra, I'm going to take an offshoot to you now. You spoke about the psychological issues which women with hirsutism face. I mean, you think the stigmatization, which, as I said, I mean, it could be social media, it could be peers, it could be colleagues, it could be family, the effect of society on the quality of life in women with hirsutism. Do you think all this plays a very major role at this point of time? I mean, we've become hypercritical as a society. Every lens matters, every pout matters. What do you think, Indra?
Yes, Dr. Shaila, that is a very important question. So, yes, we as a society and also as physicians are more often than not, let's say, causing more hurt to our patients with hirsutism. So, for example, societal factors like, let's say, staring or giving unsolicited advice, and also the societal concept that anything that is to do with the skin problem has to do with deficiencies in hygiene and lifestyle. And in that way, physicians had been judgmental and telling patients like, you're obese and that's why you're hirsute, and therefore you go and exercise, you diet and do laser and waxing. So things like that. So that is an insensitive way of approaching it. Again, in the EGBAC study, that was the experience which the patients faced, where they felt that, physicians were not paying too much attention because, let's say, in the sense that they were not giving them the proper advice for the hirsutism. Probably they thought that was not serious, or they did not understand it, or referring the patients for some other form of treatment, like not particularly paying attention to it. In this context, I came across one patient anecdote which I read on internet, which is true and painful. So this lady writes that she has got hirsutism. So to get a man, she has to, let's say, wax, she has to take laser and has to take pills. But to keep the man, and so as to have children, she has to stop the pills and get back to her hairy self. So we do cause a lot of stress for our patients with hirsutism, whether as a society or even as physicians, and we need to evolve and grow.
That's fantastic. That's really fantastic. That anecdote was really touching, Indra. And Sambit, if I can take this to you, you mentioned that there is a, correlation between mood. You said there's a correlation between psychiatric disorder and fertility to the extent of almost 40%. But is it something, I mean, is it like the cause of, I mean, is the fertility the cause of the psychiatric disorder? But you also mentioned that patients who have depression can also contribute to the infertility. So what is it like? Is it a chicken egg situation over here? Is there some kind of cause effect relationship between, these mind disorders and fertility?
Yeah, I think that's very pertinent question, and it's exactly the chicken egg hypothesis. Basically, we have sufficient evidence that infertility can lead to various psychiatric abnormality, and I just discussed in my first question. But the same is also true that psychological abnormality can lead to infertility. But whether that's a hypothesis or that's a truth, I think the plethora of evidences are lesser compared to the other point, like infertility leading to depression and anxiety. But nevertheless, there are evidences, and there are some good evidences also. Like Lappen et al. Have shown in a large study that people who have depression or significant depression have almost 2 to 3-fold increased risk of infertility. But the causes of infertility are so varied that only telling that depression is causing infertility is difficult to prove. But there are many proposed mechanisms that anxiety and depression can lead to this infertility, and one of them, and most important, as we are endocrinologists, we should be knowing what are the endocrine abnormality that may happen with anxiety and depression. One proposed mechanism is elevation in the prolactin level with depression that may lead to some luteal defect and other things, and there might be abnormal regulation of the LH or luteinizing hormone. The pulsatility and the amplitude may be varying, and that has been proven also. The depression and anxiety can lead to altered immunofunction, and it has also been ascribed to deranged reproductive function, and that has been shown by some studies. Beside that, we all know that depression and anxiety can lead to some associated altered behavior, like smoking, alcohol abuse, maybe low libido, and that may interfere with reproductive success. For male factor infertility, I think one of the major causes is anxiety and depression, because male factor erectile dysfunction and decreased libido are consistently associated with, or they are caused by a significant depression. So it's basically a chicken and egg hypothesis, as you have told. So, and both are correct.
So Sambit, that means we need to have a more holistic approach and look at the problem from all angles rather than having a bird's eye view of the issue,
Yeah,
I guess, right?
If
Chitra, I understand that, we are running against time, but I want to take this to Chitra. Do you have any evidence? I mean, do psychosocial interventions really help as far as metabolic parameters go, Chitra? Or do you think that this is more hearsay?
Right. So now that we've identified that mental health concerns might be greater in women with PCOS, does it now be of any use, or will it benefit anybody if we address this through psychosocial interventions? That's the question, right? So I was surprised at the amount of evidence that is there in this area. I was really shocked. In November 2021, a large meta-analysis was published with close to 127 papers which qualified, where interventions looking at these specific aspects improved. There's proof of concept evidence that it improves, let's say, sleep, quality of life, body image, depression. But as physicians, you and I are always wondering about metabolic parameters. There is now trickling evidence that there is an intervention can bring about changes in metabolic parameters. The study was done in China. Small group, around 18 people, divided into two groups. One group received 6 weeks of 3 hours intervention, which was integrated body, mind, spirit, the exact spirit and theme of this conference intervention. And they showed that at the end of that whole study, there was a drop in triglyceride level and also a drop in testosterone level. So I think this kind of evidence is probably what physicians, gynecologists, dermatologists, endocrinologists will pay attention to, more than if I come and say the patient's quality of life improved. So I think there is scope here for us to collaborate and to design these intervention programs, because you and I don't understand, right? How do I make an intervention which is body, mind, spirit, right? So we'll have to speak to the experts who are the psychologists, right? Maybe design a program and be open to it. Be open to the fact that maybe, yes, this can bring about interventions, not just metformin and not just the prescription of exercise by itself. Over to you, Dr. Sheila.
I think we will have to evolve our lateral thinking, Chitra, to be very honest. There's still a lot of work to do as far as lateral thinking goes over here. But I loved your synonym of mind, body, and spirit, because I really believe that's the best way forward. And Indra, how do you think that we can make life better for women with hirsutism? As clinicians, as a society, how do you think we can become more sensitive as human beings to our, to patients who are living with hirsutism?
So yes, I think that's the most important part of the questions you asked. So I think we as a society and as clinicians need to evolve to educate our patients and have empathy. So we actually should tell ourselves, evolve in the way we should tell ourselves, our children, our friends, that it is not right to stare. And then another thing is that we should actually redefine our tubular vision of what constitutes a normal physical appearance. So that is very important. And I feel that terms like male pattern of hair distribution or unwanted hair should be done away with. And let's use terms like androgen dependent hair. And also we all need to remind ourselves, each of us, that all of us are beautiful in our own way. We need to educate our patients about, let's say, the treatment and the cause of hirsutism, and when are the conditions when they need to actually look for more sinister signs and symptoms, and when is it okay to just ignore it if they're ready with it. And I think as physicians, we need to understand, like as Dr. Chitra has put, and I agree to it, that not only the disease, but also the patient. Try to look at the disease from the patient's perspective and share examples like, if I were in your place, maybe I would have felt the same way, but it's a fight we're going to fight together. So these are the things we need to tell our patients. And I think, again, from the patients, what can the patient do? Patient needs to be positive and brave. Again, telling for one anecdote from a patient, from a 20-year-old girl on the internet I just came across, who has idiopathic hirsutism. What she said was that, I'm 20 years old, I have hirsutism, but no other problem. There's no bodily problem. So it's not my problem, it's your problem. And therefore, I'm not going to take birth control pills for you. So that sort of positive attitude should be there.
Yeah, I totally agree with you, Indra. And I really hope and wish that, someday as a society, we reach a point where, as you said, your 20-year-old girl can say, okay, that's not that's your problem. It's a question of correcting your vision rather than mine.
Yes.
So totally agree with that. Sambit, you deal with, you've been talking about a very sensitive topic about infertility. And sometimes a topic which is not discussed very openly also. People do not like talking about it that openly. How would you approach and deal with the problem, in a more sensitive way? What would your advice be? When you're talking to maybe an infertile couple, you're talking to a family dealing with it, how would you really help them?
Yeah, I think infertility, we have discussed about infertility and psychological issues, and we know that both the sides are correct and we have good evidences. But is any intervention on psychological issues is going to help the couple is another third point which we must have some evidences. And in the literature search, I found a lot of articles on that, and there is a large meta-analysis, a Cochrane review, and all have concluded that with proper psychological intervention, it's quite impactful in reducing the psychological stress. And many studies have shown that those who are non-ART patients, they experienced significant higher pregnancy rates. Somehow the ART people have no increase in the pregnancy rates as per the evidences. And they have also told that the group interventions are more effective than individual counseling. And both men and women have equally been benefited. I was actually surprised what Dr. Vaishali has been telling for the last few years about mind-body program is actually true, and it is highly backed by evidences. And I could find that there is a US program which is running from 1987. That's exactly the mind-body program of infertility. And there are many studies which has been done on that thing. They've actually made it a 10 sessions program, and they have given cognitive behavioral therapy in the first 2 sessions, some relaxation training in the 1 or 2 sessions, then lifestyle changes, journaling and self-reflections, and social support components. And large RCTs have actually proven that if a couple is undergoing this mind-body program for infertility who have been suffering from these psychological issues, the pregnancy rate has been significantly improved. So I think it's a good concept, and I must congratulate Dr. Vaishali for bringing out this concept, which we actually don't know, and we must address that issue.
Thanks for that, Sambit. I totally agree with you, and I totally actually agree with all of you all. But I think we all need to grow as clinicians. We need to be having these conversations amongst ourselves, with our colleagues, with our patients. And I think that is where we would become more sensitive as clinicians and be able to probably offer a better quality of life for our patients. So I'm so glad we've had this conversation, and I learned a lot over the last 35 minutes that we've spoken to each other. It's been a fantastic session, and I'm sure everybody who's listening on to this is going to go home with a lot of notes regarding how we need to, look beyond the physical appearance, how we need to look beyond labs, how we need to be sensitive as far as our conversations are concerned, how we need to understand that maybe there is something beyond what we are seeing on paper. Like, for example, the way Sambit said that, potentially it could be actually the depression and the anxiety which could be preventing the pregnancy from occurring, to help our youth evolve and grow beyond the societal pressures that all of us at some point of time or the other face. Over to you, Vaishali. Thanks for having all of us over here. It was absolutely great talking to my colleagues, and I'm so glad to hand it over back to the organizers. Thank you very, very much. And I think whatever we now need to, whichever question and answers we need to answer, if I'm allowed to say this, the 3 musketeers are absolutely ready for it. Thank you very much.
Thank you.
It was an absolute great recording. We actually learned from each other, and in the bargain also, I think, did evolve somewhere as human beings. So if there are any questions which, as I said, the fantastic team needs to take up, we'd be more than happy. But I couldn't see any questions in the question box. So if there's nothing further, I could hand it over back to the organizers, because I understand we're running late, and the organizers would want us not to take up too much time.
Thank you, Dr. Shaila Sheikh.
It was an absolute pleasure. Thank you very much.
Thank you for this nice presentation.